Good evening, everyone in India, and good morning to everybody who's joined from the other parts of the world. Today, I think we'll be kick-starting the webinar series with a wonderful talk by an eminent person, Dr. Milind Rajadhyaksha. So I have a very brief intro to him, to the audience, which is of a mixed kind. Dr. Milind Rajadhyaksha is actually a mechanical and optical engineer, and he's a principal investigator in the optical imaging laboratory at the Dermatology Center in the Department of Medicine and Memorial Sloan Kettering Cancer Center at New York. He's also professor at the Weill Cornell Medicine at New York. He develops a confocal microscope for imaging guided non-invasive diagnosis of skin and oral cancers. His work spans the entire spectrum from bench to bedside, laboratory research through commercialization, through clinical studies to clinical implementation. And he enjoys working in the so-called valley of death and living through frequent near-death experiences between laboratory and clinic and between academia and industry. Interestingly, we had a brief chat before the beginning of the session where he was talking about his collaborations with the Tata Memorial Hospital at Mumbai, and I'm sure we will hear more about that. The two of these microscopes have already been commercialized, Viva scopes, and I hope to hear more about them in this talk. These have been validated through clinical trials, granted reimbursement codes, and are now in routine use at the bedside to non-invasively guide diagnosis, treatment, and management of skin lesions. A third microscope is currently in development and clinical testing for diagnosis of oral lesions. And today he is going to talk to us on reflectance confocal microscopy of skin and oral cancers, technology, clinical research, early impact on patient care. Over to you, Dr. Milind.
Thank you very much, Uma, for your introduction, as well as thank you to you, Jyotsna, and thank you to Saima for asking me to speak to all of you about my work. Once again, hello to all of you, and I wish you all a very good evening in India, as well as a good morning to all of you in the US. And for colleagues who are on the West Coast, Ruchi and any other colleagues, thank you for waking up early. And I wish you all also a very happy new year. So let me share my screen. Can you all see my screen?
Yes.
Great. And can you also see my cursor as I move my mouse around?
Yes, we can.
Excellent. Great. So I'm going to speak to you about reflectance confocal microscopy of skin cancers. And I'll give you a sense for the technology that we've created, clinical research that has taken place over the last more than a couple of decades now, and the early impact of this imaging approach on patient care. Confocal, as many of you in this audience will be aware, confocal microscopy of skin, and really the entire field of optical imaging and spectroscopy of living tissue, so optical imaging for biomedicine, started to grow quite rapidly in the early 1990s, which is now more than 3 decades ago, starting with the development of new devices, new instrumentation, new technologies. And since then has evolved into what has today become a rather lively, a rather active, and a very vibrant area of work, as all of you are well aware. So much so that some of our imaging approaches have in recent years progressed all the way to the bedside and are being used to non-invasively detect and diagnose skin conditions and help guide patient care. This is now happening in a number of different clinical settings worldwide. And we have our first technical problem. My slide's not. Okay. Good. Can you see my second slide?
Yes.
You can see. Great. Thank you. Yeah, thanks so much. So all of the work we've done in skin and all of the progress we've made in imaging of skin cancers and our success so far has now set the stage for what we're going to do next, which is imaging to help non-invasively detect oral lesions in India. And as I'd mentioned earlier, this is a very new initiative that we've started with our colleagues at Tata Memorial in Mumbai, Dr. Pankaj Chaturvedi and Dr. Arjun Singh. So I'll share with you a little bit about the work that we've just started at Tata Memorial, especially at their ACTREC location in Kharghar. The very first paper on confocal microscopy of human skin in vivo was published back in the year 1991 by Jamie Jester, a well-known ophthalmologist in our field of biomedical optics. Then came a string of papers from a famous pair of physicists, Pierre Carcouf and Jean-Luc Lévesque. And at the time, much of this work, or in fact, all of this early work was with white light confocal microscopes, meaning that their microscopes use white light sources for illumination. By the way, if you can, wherever you are, shut down the room lights, because when I show you images and videos, you'll be able to better appreciate the detail in all the images if there's no glare coming from your monitor. So if possible, I'll suggest for you to shut down the room lights wherever you may be located. So all of this early work was with white light confocal microscopes using white light sources for illumination. Then came our group, and we were the third group to enter this field. And by our group, I'm referring to my two mentors, Rob Webb, who was a very well-known physicist and a pioneer in building confocal microscopes for imaging of the retina and for ophthalmology. So I learned all about microscopy and microscopes from Rob. And Rob Sanderson, who is a legendary name in dermatology and a pioneer in having created many different laser-based techniques and approaches for treating skin conditions. And I learned all about skin and pathology and clinical work from Rox. At the time, I was a postdoctoral research fellow in their labs at MGH in Boston. And we started building laser-based confocal microscopes using lasers for illumination. In the meantime, a couple of our colleagues in the industry had started building handheld microscopes and were looking for ways to commercialize this imaging technology. All right, so it's time for my daily confession. A couple of my microscopes have been commercialized by the company that I just mentioned to you, Caliber Imaging and Diagnostics, based in Rochester in upstate New York. Rochester is not too far from New York City. It's only about a 5-6 hour drive. And a long time ago, after finishing my postdoctoral work at MGH in Boston and before joining Memorial, I'd worked for the company for a few years. I was involved in commercializing my microscopes. Back then, we were a small and a startup company. I now happen to hold a tiny slice of equity. Okay, so why do we care? Why do we care about non-invasive approaches for detecting skin cancers? Well, as many of you in this audience may be well aware, among all the cancers which occur today, skin cancers occur with very high rates of prevalence and very high rates of incidence, not only in this country, but also in many other countries around the world, particularly, of course, in regions where people have fair skin. Every year in this country alone, something like more than 5 million new cases are being detected, for which millions of biopsies are being performed. Now, depending on the setting, it turns out that anywhere from 60% up to 90% or more than 90% of these biopsies turn out to show skin that's benign. In adults, in the adult patient population, anywhere from a couple of biopsies up to 10, 30, 40, 50 biopsies may be taken of benign skin conditions for every detected malignancy. And among children, in the pediatric patient population, among teenagers, the situation is worse. Anywhere from a couple of hundred to a few hundred biopsies may be taken of benign skin conditions for every detected malignancy. And so the question, quite obviously back then, was, can we do something better? Can we come up with better ways to detect skin cancers? Can we do this non-invasively? Could we do this in real time at the bedside? And the question that we began exploring is whether we can do this with confocal microscopy, a high-resolution optical imaging approach that has the resolution to show us patterns of cells and patterns of nuclei, nuclear cellular morphology, the kind of detail that pathologists look for in biopsies and in pathology. And of course, as you're aware, many of our colleagues in industry and in academia were looking at the same question with a number of other optical approaches. There's optical coherence tomography, multiphoton microscopy, Raman spectroscopy, diffuse reflectance, and diffuse fluorescence spectroscopy. The field is just rich with many of these techniques that have been researched over the last now more than 3 decades. And if you look outside the US, particularly in some regions of Europe, in UK, Australia, you're looking at about another 1 million or so new cases being detected every year. So this is truly a global problem, and it's a significant problem in many countries around the world. Visual examination and dermoscopy are routinely performed in the clinic. Think of a dermoscope as a magnifying glass, typically about 4x magnification, typically 10 microns resolution. With dermoscopy, the sensitivity can be typically very high, but the specificity oftentimes tends to be lower and tends to be variable. True, especially for skin conditions which lack distinct appearances. So if you look at, or lesions which lack features and lack patterns. So for example, if you look at these two cases, you really cannot tell whether what you're looking at is simply normal skin or whether there may be something potentially malignant below the skin surface. And we could perhaps put Gopal on the spot and have him make a diagnosis for us, but I won't do that to you, Gopal. So with the result that many of these lesions remain indeterminate with dermoscopy, and that results in a large number of false positives, which then leads to large numbers of biopsies of benign skin conditions. And I just mentioned to you the benign to malignant biopsy ratios in the adult and the pediatric patient populations. So dermoscopy is a form of conventional volumetric microscopy, meaning that with a dermoscope, one can illuminate, one can image, one can examine tissue in the entire volume of the skin lesion. So within the volume, one can look at patterns of pigmentation, patterns of morphology, patterns of blood vessels, and patterns of blood flow. But clinicians, we cannot look below the skin surface to look at patterns of cells and patterns of nuclei. We cannot look at nuclear and cellular morphology, which is why oftentimes beyond dermoscopy, as all of you are well aware, clinicians then proceed to performing a biopsy. We take the biopsy piece of skin and cut it into thin sections and stain to look at under a microscope. And that's how pathologists can look at patterns of cells and patterns of nuclei to arrive at a diagnosis. And this, of course, is the traditional process of biopsy and microscopy and pathology. But with the confocal microscope, with confocal microscopy, or with the confocal microscope, instead of having to physically take a biopsy and physically cut tissue into thin sections, we can perform what is known as non-invasive sectioning with optical imaging, or non-invasive optical sectioning. And we can now start looking at individual layers of cells and nuclei below the skin surface. We can do this in vivo directly on the patient. And these are example images showing you normal human skin epidermis. This is the basal cell layer in the epidermis. And if you look very closely, you'll see these rings, bright rings. Each ring, can you see I hope you can see my cursor. Each ring is a single cell. That's about 10 microns in dimension. And so these are clusters of cells in the basal layer. And example images of melanoma skin cancer showing you patterns of melanocytes, and basal cell carcinoma showing you patterns of elongated and polarized dark nuclei. All right, time for a brief tutorial. Now, I'm an engineer by training, as all of you are aware, and of course, I love theory, I love math, I love equations, but I won't subject it to any of that today. After all, it is a Saturday. And so what I'm going to do is give you a very simple and a very conceptual explanation for what a confocal microscope is and how it works. So I'll keep it very simple. A confocal microscope is made up of a point source of light with which we illuminate a small spot within tissue. This is called an illuminated voxel within the tissue. And for any of you who may be familiar with the theory of optical imaging, this is the illumination point spread function. Light which is reflected, rather light which is scattered back from this voxel is collected through a small pinhole onto a detector, and that will produce a pixel. This is singly backscattered light. This is light which is in focus coming directly from the voxel. Light which may have been multiply scattered within the tissue, light that may have bounced around and becomes out of focus haze. I've shown that light here by these red and green dotted lines. This light is spatially filtered or rejected by the pinhole in front of the detector. Okay, so by using a pinhole, we force the detector to collect only singly backscattered light which is in focus coming from the illuminated spot. A very clever approach to look at only in focus light, but oftentimes not very practical or not very useful, because we need to look at large areas or large volumes of tissue. Particularly if you want to do diagnostic type work, you need to look at large areas or large volumes of tissue on your patients. So what do? Well, we scan the voxel in 2 dimensions. And by the way, this is my rather pathetic attempt at PowerPoint animation. This took me many hours to figure out on a Friday afternoon, at which point I decided to stop, get on with the rest of my life, and let you, the audience, imagine what happens. But imagine the voxel being scanned in 2 dimensions. So for example, if you see my cursor, or if you point a laser at the wall, or if you have a paintbrush and you paint back and forth, that's called as raster scanning. And so what we do with the raster scanning approach is we now create a plane of voxels. And while we do the scanning, we keep getting back light that is out of focus, all of the out of focus haze. That light continues to be rejected by the pinhole in front of the detector. And as the voxel is scanned, we collect light from each location. Each of those locations will now produce a pixel, so that we now have a collection of pixels which produces an image, much like you have an array of pixels on your laptop monitor, or you have an array of pixels in your mobile phone camera. So by using an illuminated voxel, by using a pinhole, and by scanning, what we can now do is start imaging that a thin plane or that single plane which is in focus within skin or within tissue. And we can do this non-invasively without the need for biopsy or without the need for physical sectioning. So this is known as optical sectioning or non-invasive sectioning with a confocal microscope. And I hope all of this is clear to you. By the way, feel free to jump in and ask questions or give comments as and when you'd like to. So back to dermoscopy, which is a form of volumetric microscopy. We have no optical sectioning. Our depth of field is typically tens to hundreds of microns. We don't reject any out of focus light, but as you've gathered by now, with a confocal microscope, we can perform non-invasive optical sectioning, and we can now start looking at individual layers of cells and layers of nuclei directly in vivo. This is the original scanning laser benchtop microscope that I built. This was back when I was a postdoctoral fellow at MGH. What we have in this benchtop microscope is a collimated laser beam, which serves as a point source at infinity. That light is focused to a voxel through a standard microscope objective lens. That voxel is scanned in 2 dimensions with 2 scanners. In my setup, I used a spinning polygon mirror and an oscillating galvanometric mirror. And as the voxel is scanned in a plane within tissue, we collect light from each location. Light is collected by the same objective lens. It goes back the way it came. It comes up to what is called as the beam splitter, at which point it separates from the incoming light and is focused through a pinhole onto a detector. The pinhole here is optically conjugate to the voxel within skin, and that's what makes this microscope confocal. I thought I might amuse and entertain you by showing you some of my very first images of skin, or depending on your point of view, you might be more shocked than amused. Turns out that the images above, in the top 2 panels, are from a piece of rabbit skin, and the images below are showed you skin on my arm. And really awful imaging, really bad imaging. It took me more than a couple of years to build a microscope, and it took me a couple more years to sort through all of the optical details, the electronics, trying to figure out ways to improve optical sectioning and resolution and to reduce speckle noise and electronic noise, until we got to a point where the image quality was beginning to look good enough for diagnostic use. But any new technology, that's how we make a beginning with any new device or any new technology. This is an example of my many measurements of axial response functions, which gives you a sense for detected signal fall off from the focal plane or from the optical section. The full width at half maximum of such axial response functions gives you a measure of optical sectioning, meaning how thin or how thick your optical section might be. And the tails of such functions gives you a measure of how much light you will collect as you move away from the optical section. This is the multiply scattered out of focus haze. Some of it will get into the detector through the pinhole, and that will then reduce the contrast in the images. So with a well-designed, well-engineered, well-assembled confocal microscope, you can expect a sharp axial response function, meaning that you can get really sharp sectioning, you can get thin optical sections and high resolution. And that's the kind of imaging that we typically see in the epidermis or in the epithelium. But as we go deeper, as we go beyond the epidermis or the epithelium into the deeper dermis or the deeper connective tissue, the axial response function begins to degrade, as shown by the red plot here. The section becomes thicker and the tails become wider, meaning that we start collecting more and more light that is out of focus and away from the optical section, and that begins to reduce contrast in our images. And this happens because of the influences of scattering and aberration as we go through all of the upper layers of tissue. So looking at connective tissue through the epithelium, looking at the dermis through the epidermis, is in many ways similar to looking at the moon on a cloudy night. And the moon appears quite sharp when you look at the moon on a clear night, but when you look at the moon through a thin layer of clouds, the moon starts appearing fuzzy, and that's because of the effects of scattering and aberration. Similar effects happen in tissue with imaging, with optical imaging, as well as with all other forms of imaging. A similar situation with resolution. So if we were to image a sharp edge, we can expect a sharp edge response function, as you can see here in the plot on the right. But if you image that same edge through a piece of human epidermis, the edge starts appearing fuzzy and the edge response function begins to degrade. And that gives us a sense for how resolution will degrade as we image deeper and deeper into skin. Okay, back to my benchtop setup. This setup occupied something like 2 feet by 4 feet of optical bench space. There's a whole rack of electronics, which you don't quite see in this picture. And of course, this was a benchtop setup that did not go anywhere. So we would bring patients into the lab, place them on a gurney, and shove them up against the objective lens. And that's how we got started with some of our very early imaging studies. And this is what we now have in the clinic. As I mentioned to you, my microscopes were commercialized by this company, Caliber Imaging and Diagnostics, and Jim Zavislin, Bill Fox, and Jay Eastman led the commercialization work at the company. This is now a 4th generation confocal microscope. This has been around now for a couple of decades, has been the workhorse in the field, has been used in a very large number of studies and trials, and is now being used routinely at the bedside in many clinical settings worldwide. With this microscope, we typically collect mosaics at the dermal epidermal junction, which can be read to help guide diagnosis. So our imaging is typically with 30x magnification that shows a rather small field of view. After all, this is microscopic imaging, but we can collect and put together a 2-dimensional matrix of images, which is what I'm showing you on the right here, to create mosaics that will display larger fields of view or larger areas, which is very necessary for all of you as clinicians and for pathologists. And we can zoom into such mosaics to look at skin with different magnifications, with different fields of view, while maintaining or while preserving resolution. So this approach with mosaicing really mimics the process by which our pathologists look at pathology, which as all of you will be well aware, starts with 2x magnification. That shows 10 millimeters by 10 millimeters field of view. And then the pathologist will zoom in to more closely look at areas of suspicion, typically with 4x magnification and with 10x magnification. So we mimic this process with our mosaicing approach. I'll show you some example mosaics. This is of a melanocytic skin lesion, meaning a pigmented spot, and all of us have pigmented spots on our skin. And in this particular mosaic, what you're seeing are ring patterns of basal cells sitting on the dermal epidermal junction. By the way, our imaging is in the en face orientation, not in the traditional vertical orientation with which we see pathology. So you'll see skin here, skin will appear different to you in these images. In this particular mosaic, the ring pattern appears quite disrupted. What we are seeing is epidermal disarray. This happens to show you a melanoma skin cancer. And in this mosaic, what you're seeing are darkish grayish nodular nests of tumors. This happens to show you a nodular type of basal cell carcinoma. We also have a handheld confocal microscope. Very useful for acquiring videos with which we can perform video mosaicing, which is useful for mapping margins, which can help guide surgery. And here's an example video mosaic showing you completely mapped margins of a lentigo maligna. This was performed prior to the start of surgery. And if you zoom in and look in these video mosaics, there's a lot of detail here, patterns of dendritic cells, as well as other patterns of morphology, which can help delineate margins and can help guide surgery. Okay, so this brings me to the end of the first portion of my talk, which was to give you an introduction to the basic principles and the technology. I'm now going to switch topics and we'll talk about imaging. I'll show you images. We'll talk about some of our clinical work. But the question I have for you, Uma, is whether at this point, should we take a break and see if anyone has any questions or any comments, or would you like for me to keep going?
Now, I have no problems. Is there any pressing question from the audience?
Yeah, I have a question, ma'am.
Yeah, go ahead,
Please.
Gopal.
Yeah, like in the dermatology setup, as we see in the Indian skin, we don't see the melanoma so frequently. Okay, so what we see are generally the pigmented disorders as well as the eczemas or psoriasis or the what we can say a papilloscomal disorder. So like you explained the optics and everything about the same. So does this fuzziness or scattering will increase when the epidermis will be heavy?
Yeah. So there have been
Psoriasis, like there are a lot of scales are there. So is that scales and everything is going to create a more problem in diagnosing this condition vis-a-vis compared to the BCC or SCC or the melanoma sort?
Correct. So if you look in the literature, and maybe you're aware already, there have been a number of studies looking at psoriasis and other skin conditions. And it is true that whenever you have epithelial or epidermal thickening, or if you have keratinization, all of that does limit the depth of imaging. And so those are some of the limitations with reflectance confocal microscopy. That is true.
So in what we do is generally in this case, like in dermoscopy also, when we do it, if we are performing a polarized vein or not. So what happened is if we are doing a polarized, still we have to put linkage fluid in that area. So if
Right.
the linkage fluid between you whatever the what we can say moving platform that is in touch with, and we include a linkage fluid, does that linkage fluid is going to affect the image? Or is it not going to affect the image? Linkage fluid is just, it can be sterlium also, it can be a gel also, it can be oil also. Is it going to affect the optical imaging?
That's a great question. And, we haven't really explored the whole idea of trying to introduce fluids or liquids into skin, at least not on patients. A lot of work has happened in animals and in excised tissues. And so there is a possibility that you can actually do optical clearing with some of these fluids. And just as in dermoscopy, where you apply oil, we could do that. All of that will affect imaging, because this is microscopic imaging, which is very sensitive to the optical conditions within tissue. But it is possible. I mean, it's something that you might consider trying, at your end.
Yeah, let's see how it goes. Thank you.
Yeah, and let me talk to some of my colleagues, particularly in Europe, who may have tried some of this that I may not be aware of.
Yeah, I had an interaction with some Italian group also regarding this RCM, because in India normally we see the pigment anomalies.
Right.
Okay, like sinus pigmentosus or EDP, like erythema descomicum perstans or melasma, sometimes mixed with the post-inflammatory hyperpigmentation. That.
Yeah.
So they got it. So they are, I am much more interested in this condition as well as the Wilson condition. While interaction with them, they had told me that yes, the fluid concept can be applied in that, though like they had answered in the negative, like you haven't tried on their patient. So they would also like to try it. Since you are an inventor, like you are a OEM of this, and you know inside out of this equipment, so you can do it on your patient. It's not like we are just applying a linkage fluid. We are not doing any invasive procedure like that.
Sure, yeah.
So whether it can improve the optical quality or whether it deteriorate the optical, it's putting a fluid and taking a picture pre and post. So you can do it and you can share the images with me possible. So we will be also.
So one thing that we tried and a couple of our other colleagues tried was glycerine introducing glycerine into the epidermis and the dermis, and then using an objective lens specialized for imaging through glycerine. So
Yeah.
something like that might work, and the question is whether you would want to do that routinely on your patient. But we can discuss more offline about what may be possible.
Yes.
Yeah, but that's a great question, because that's something that remains one of the unanswered questions, and we haven't quite tried much in terms of clearing of skin with any optically clearing liquids or fluids.
Liquids. Yes. Correct. Thank you.
Yeah.
Thanks.
Great. All right.
I do have a couple of questions as well, if I may. This is Amol from Atlanta.
Yeah, Amol, go ahead.
What's the depth of your imaging?
A couple of 100 microns. So typically, we can image through all of the epidermis or the epithelium. We can go through the dermal epidermal junction and reach the underlying papillary dermis. So about between 100 to 200 microns.
So then in cases for melanoma where, the Clark's level are important for depth and all that, this is mostly for diagnosis, not determining the extent deep, more like
Correct.
superficial spread.
Correct. So the imaging, with that depth, the imaging really is useful for looking at early stage conditions.
Okay.
Where much of the morphology is confined to the dermal epidermal junction or the basal layer or the epidermis or the superficial dermis. And where the imaging has had most impact has been in trying to define conditions that are benign and saving biopsy, which is what I'm going to talk about very soon.
Okay.
Yeah,
because even in
the moment you have to start imaging deeper, then one has to rely on biopsy and pathology for anything that's beyond early stage or moderate stage.
Yeah. Even in mucosal oral cancers, the new TNM staging had introduced the concept of depth, which we were struggling even with regular imaging and clinical evaluation.
Right.
But I guess even you guys would with confocal imaging, it's still going to be a challenge. The other question I had was, when we make with traditional microscopic evaluation and H&E staining and all the other stains we use, we look at different characteristics of the cell under the microscope, nucleoli and large cells, and those kinds of characteristics, mitosis per field of view and all that to come to a diagnosis of cancer.
Mm-hmm.
Do you see similar characteristics with confocal microscopy? Because I'm presuming there's no staining involved in this live superficial skin that you're imaging directly from patients.
Correct. So what we see is not pathology, but what we see is morphology.
Okay.
And so, we don't see nucleoli and a lot of the microstructural detail, because you're right, we don't do any staining. This is all, based on endogenous backscattered light. So it's similar to ultrasound imaging without the use of any contrast agents. And so, as you can imagine, some of the features have a direct correlation to what's seen in pathology, and some of the features don't. And so what has happened over the years with all of the clinical work is that my colleagues have figured out how the imaging can be an adjunct to pathology.
So it's basically a high resolution morphologic imaging techniques,
Right.
with combination of microscopy and ultrasound, actually.
Yeah, exactly. And the main thing is really to be able to distinguish what's benign beyond dermoscopy and avoid biopsies. And then everything beyond that requires biopsy and pathology. And
then, because the next step for once you define if it's malignant, the next step for future work in your field would be to see, because the field in oncology is heading towards biomarkers and various targets on the and so if you could non-invasively get an idea whether this lesion on the surface of the breast is recurrent breast cancer versus something else, melanoma, that would be very interesting.
Correct. And so I'm going to talk only about our work in vivo, but we have a whole other line of research building microscopes for imaging excised tissues ex vivo. And,
awesome.
And with ex vivo, of course, you can use all sorts of stains, and we can do rapid pathology at the bedside, which is what is also happening with our most surgeons and some of our other surgeons. And also with us, we have Aditi Sahu, who is the senior research scientist in my group, and she's begun to look at work. She's been looking at the tumor immune microenvironment and looking at some of the biomarkers. So we can talk more about this offline if you'd like.
Awesome.
I'll ask Aditi to talk to you as well, Amol.
Perfect. Sounds good. Thank
Yeah,
you.
yeah. Lots going on in the field, especially also with imaging of excised tissues, which we can talk about.
Wonderful.
Great.
Any other questions? Okay, so I think your talk has already piqued so much interest. So looking forward to the next part of your talk.
Okay, so the next part will be more relevant to many of you, which is going to be all about the clinical work that has taken place over the last now more than a couple of decades. So pathology, as all of you are well aware, is based on looking at sections oriented orthogonal or perpendicular to the skin surface. But the laws of optics are such that with confocal microscopy, the best resolution and the best imaging is in planes oriented parallel to the skin surface, the en-face orientation. So we can visualize skin in non-invasive en-face optical sections. And as I mentioned earlier, the images, skin will appear different to you than what you may be familiar with in vertical sections of pathology. Our imaging is based on the detection of singly backscattered light from the optical section. Remember the pinhole in front of the detector that collects only in focus singly backscattered light. And refractive index variations between all of the different structures in tissue is what produces endogenous backscattered contrast. We say reflectance confocal microscopy just for convenience to separate ourselves from fluorescence confocal microscopy. But really, we're looking at not reflected light, we're looking at backscattered light. So with backscattered contrast, nuclei appear dark because of weak backscatter from all of the chromatin that's within the nuclear volume. But the surrounding cytoplasm appears bright because of strong backscatter from melanin, from keratin, and from all of the organelles and structures that are present in the cytoplasm. The pigment melanin has a high index of refraction, and melanin is packaged into tiny granules called melanosomes, which are strong backscatterers of light, with the result that melanocytic skin lesions, pigmented skin lesions, melanomas, as well as amelanotic non-pigmented melanomas image with exceedingly strong brightness and strong contrast. So in reflectance or in backscattered mode, melanin behaves as a contrast agent or a stain. Okay, so at this point, I will show you a video just to give you a sense for how normal skin appears with a reflectance confocal microscopy. And you'll see all the different layers that make up the epidermis. And I've shown example images here on the left, going from the stratum corneum down to the basal layer at the dermal epidermal junction. And then below the epidermis, to answer your question, Amol, we can image into the papillary dermis. We can see blood flow in the papillary dermis. And on a good day, we might reach the beginnings of the reticular dermis, although most days in the clinic are not good in terms of imaging. We don't go that deep.
Awesome. Can I briefly interrupt just for a second?
Yeah, go ahead.
You've been using terms that we use a lot in nuclear medicine, actually, full width heart mass and
Yeah,
scatter and
right.
all those.
It's
So I'm just
physics.
curious, what kind of reconstruction algorithms do you use? And, do you have scatter correction and filtered Bragg projection, iterative reconstruction? What kind of things do you do to generate this image? Because
No.
you are subject to same limitations that we are in our field. It's a horizontal field of view, and you can get scatter from adjacent areas that may kind of cause noise in your image.
Right. So with confocal microscopy, the optical sectioning is so good that we don't do anything. These are raw images. This is what you get directly from the microscope, because the optical sectioning is about 3 microns, which is equivalent to a 5-micron thin section of pathology. The resolution is a micron. And so there's very, very good rejection of out of focus light. We have done 3D reconstructions to look at skin in vertical sections, but the resolution in the vertical section is about 3 times worse. And so you don't see the same kind of detail that you see in these images. But almost these are all raw images, completely unprocessed.
Wow.
And by the way, the imaging will
incredible.
look even better to you in oral mucosa, which is less scattering and less aberrating.
So why is it grayscale?
Because we rely on it's a single wavelength. It's monochrome. We're not using multiple wavelengths, not yet anyway. Some of us, not I personally, but some of my colleagues have tried imaging with multiple wavelengths. Maybe we'll get to colorized imaging at some point, but this is all with a single wavelength.
Awesome. Thank you.
Yeah.
But if we combine a lot of wavelength, the scattering will increase, I believe. That is just a random thought.
It would, yeah. I mean, it would be an interesting problem in physics and optics if you use multiple wavelengths. Everything will vary, your optical section, resolution. Yeah. We do use, we do produce purple and pink colored images with our excised tissue work because, we can stain and then we can digitally colorize our images purple and pink. And again, I won't talk about any of that today, but happy to, we could have another meeting and talk about the ex vivo work as well. I don't know, behind me, for example, if you can see, do you see right there behind me? I don't know how well you can see it, but that's actually a mosaic from an excised piece of tissue from Mohs surgery. That is using acrin orange for staining, and we can see nuclear morphology quite nicely. And then on the wall here, I don't know if I can show this to you, but if you see right there in the corner, that's a confocal mosaic from this was from a piece of tissue from Mohs surgery, and we can do imaging and we can do rapid pathology literally within minutes at the bedside. But again, I'm not going to talk about ex vivo work today.
Looks like your office is a museum of great mosaics.
Yeah, I call that tumor art. By the way, if any of you happen to be in the New York City area at any point, if you're visiting, let me know and come visit us.
Our VP is from New York City area. She's on this call, Chitra Saxena, actually.
Okay, well, I'll invite you, Chitra, to come visit us at Memorial. I'm on the Upper East Side.
Perfect. I actually visited 2 weeks ago. I'll be happy to come again.
Okay, great. All right, so let me show you this video. And again, I'll remind you to turn the room lights off, which I know is a little bit inconvenient, but the images will really stand out well on your monitor. So starting at the sternum corneum, I do hope the video plays for all of you. Going through the granular cell layers, you'll see a honeycomb pattern of cells. Going through the spinous cell layers, you'll see a cobblestone pattern of nuclei, rings of basal cells opening up on dermal papillae. And now if you look very closely, you'll see thin slivers of blood flow within the dermal papillae. Those are the capillary loops that come up into all of the dermal papillae. And then as you go a little bit deeper, you'll start seeing collagen in the underlying papillary dermis. Did the video play for all of you, I hope?
Yes, it did.
There was a little bit of lag. Can you please replay it?
Yeah, I'll replay it. So what you'll see, Gopal, are what my colleagues have described as cobblestone patterns of dark nuclei within honeycomb patterns of bright cells. And just to remind you, these are en-face images. The orientation is different than what you see in pathology. So let me play the video again one more time. And by the way, I'm happy to share my slides with all of you, all of my slides, including the videos. Can you see that now, Gopal?
Yes.
Yeah, okay.
So this is different than regular video microscopy.
Yes, this is confocal. Regular video microscopy is like doing dermoscopy, which, as I mentioned earlier, there is no optical sectioning. So, what you see, you basically see the entire volume of tissue within the lesion. This is confocal, which gives you optical sectioning. So you're looking at a thin section at a time, a 3-micron thin section.
Yeah, almost 25 years ago, I used to work on microbubbles with ultrasound and video microscopy. That was leading towards this thing, but for some reason, I see the video. Have you played with the speed of the video, because that looks artifactually slow?
So I've built microscopes that go much faster on the bench. So the original microscope that I built was at 30 frames per second, which is video rate, and everything was much faster. In the vivoscopes, the imaging is slow, and that's mainly for technical reasons. They use much smaller scanners that operate more slowly. So the frame rate on these videos is about 7 frames per second. And we find that if the lens makes contact with the tissue, then 7 frames per second is adequate to get good imaging without any motion blur. But if you want to do imaging at a faster rate, we can do that. And we have done that. Yeah. So imagine the same video running at about 4 times faster.
Yeah, once upon a time, I used to look at microbubbles in a chamber using a similar technique, and I had to play with the frame rate to get rid of blurring. So I was curious what you were doing. Okay.
Yeah. Again, what Aditi is doing is looking at the tumor immune microenvironment, and she's looking at blood flow and leukocyte rolling in addition, and a lot of dynamic events. And for that, Aditi will eventually need a confocal microscope at video rate at 30 frames per second, which I don't have in the lab at the moment, but that would be ideal for some of her work.
Thanks.
Okay. So again, to answer your question, Amol, the depth of imaging is limited to the papillary dermis. This includes, of course, this is a couple of 100 microns. Nonetheless, this depth will allow clinicians to routinely image and observe and examine the dermal epidermal junction, which includes the lower spinous layer, the basal layer, and then the underlying papillary dermis, which is what you saw in the video. Now, looking at the dermal epidermal junction is, of course, important to clinicians and to pathologists, as all of you will be aware, because in the basal layer, at the dermal epidermal junction is where most of skin disease and cancer originates. And then from within the basal layer, the malignancy may spread laterally and remain in situ, or it may invade into the dermis and become invasive. Our contrast is grayscale, again, to answer your previous question, because we use a single wavelength of light for imaging. Our imaging is monochrome. This is like in a black and white TV from the 1970s. So our images lack differential contrast for structures, meaning that we cannot always distinguish between melanocytes versus Langerhans cells, between different types of inflammatory infiltrates, and between basal cell carcinomas and tumor mimickers such as hair follicles and sebaceous glands. And there is work going on in the field, looking at contrast agents that may someday be introduced into skin in vivo, particularly one contrast agent named PARPI FL. But I won't digress into that at the moment. And then there are pitfalls for detecting and or reading some types of lesions, such as nodular melanomas that may be too deep, nevoid melanomas that may appear too bland, as well as some of the deeper and smaller micronodular and infiltrative types of basal cell carcinomas. Nonetheless, despite the limitations and despite the pitfalls, our images and mosaics do present a rich amount of detail, and you've seen some of these mosaics and images already, with the result that many of our colleagues in dermatology have learned to read these images, similar to how pathologists read pathology, and they're able to read these patterns to help guide diagnosis, with the upshot that there have been tremendous progress in translation over the last now more than a couple of decades. Now, I'm an engineer by training, as all of you are aware. And so for me, being involved in many of these studies was a tremendous learning experience. And more than that, it was just exciting to watch the imaging progress into the clinic in the hands of many of my colleagues in dermatology, not just colleagues in the US, but also colleagues in Europe, particularly in Italy and in Spain, and colleagues in Australia. So really hats off to many of my colleagues who have helped to bring this imaging into the clinic. Kudos to all of them. The upshot of a very large number of studies and trials has been that reflectance confocal microscopy, when combined with dermoscopy, will provide about 90% sensitivity. But more importantly, the specificity can be 60 to 70%, and this can be 2 to 3 times higher, depending on the clinical setting, compared to what you might get with dermoscopy alone. And so because of that, the number of biopsied benign lesions per detected melanoma, in other words, the benign to malignant biopsy ratio, can be 50 to 70% lower. So starting in the year 2013, 2014, which is now about a decade ago, many of my colleagues started combining dermoscopy with reflectance confocal microscopy to triage lesions into those that appear to be benign, and such lesions are now being spared from biopsy. So there has been a significant drop in the number of biopsies of benign skin conditions versus those that appear to be suspicious. And of course, those lesions do proceed to being biopsied and being looked at with pathology. And so based on all of this work, which took more than 2 decades, in fact, 24 years to be exact, since the time that I started building my benchtop microscope back in 1992. And it took really a global village of colleagues and collaborators and collaborations. I'm very happy to tell you that what happened in January of 2016 is that reimbursement codes were granted for reflectance confocal microscopy of skin. So a big step forward for this technology, a big step forward for all of us in the fields of dermatology and biomedical optics and imaging, a big step forward for my friends and colleagues at the company. And of course, a big step forward for me at a personal level. This was, as you can imagine, a milestone moment in my career and in my journey. So now early adoption is in progress. And as of today, I was told that there are about now 1,000 clinics worldwide which are routinely using our microscopes to detect and diagnose skin conditions and to help guide patient care. At Memorial, last year, there were about 750 imaging procedures. So on average, about 2 or 3 patients are imaged each day, about 10 to 15 patients each week. So all of this progress in skin, that was just a brief history of 30 years of work. And all of this progress in imaging skin and our success to date has now set the stage for what we're going to do next, which is imaging of oral lesions and imaging to help non-invasively detect all conditions in India. And so once again, I'll ask you, Uma, whether we should take a break and ask for more questions, since I'm going to change topics.
I'm fine with it. I think, audience, if there are any more questions. I think you had cleared most of them.
I think so, yeah.
So
All
we
right,
can yeah.
I'll keep going.
Yeah.
Okay, great. So as I mentioned earlier, this is a very new initiative that we've started with Dr. Pankaj Chaturvedi and Dr. Arjun Singh at Tata Memorial in Mumbai. You know, ever since I built my first benchtop confocal microscope, this was back in the early 1990s, and ever since we have started imaging skin and performing skin imaging studies, you know, I'd had this thought in my head that if this imaging succeeds in skin, then someday it would be nice to bring this imaging and this microscope to India to address the need for detection of oral lesions, early stage detection of oral conditions. So this is going to be now my research agenda for the next 10 years or so, or maybe even more than 10 years. So I thought I might begin by once again trying to amuse and entertain you by sharing some of our very early attempts at imaging in the oral cavity. As always, I would catch an unsuspecting volunteer, meaning a good friend and a colleague. And so this may be perhaps the world's first experiment in confocal imaging in the oral cavity. We even got a patent for this device. You know, we call this a lip and a tongue clamp. And after we'd done imaging on ourselves in the lab, we'd walk around in the hallways with this clamp hanging off our lips and tongues, pretending like we're giving a fashion statement. You know, typical geeky, nerdy stuff that we engineers are famous for. With this microscope, we should have probably spent more time imaging the oral cavity than elephants and whales and maybe other large animals. But nonetheless, we did manage to do some imaging in a few patients who were willing. We modified some of our early skin microscopes to do imaging in the front of the oral cavity. And then eventually, we had built our first handheld confocal microscope for imaging skin. And of course, this microscope had a lens that was pretty large. This was for imaging skin and not really useful for imaging in the oral cavity. So one of my engineers, Gary Peterson, put together a relay telescope probe to allow access into the oral cavity. We took Gary's probe, we built a new smaller lens, and with a disposable cap and a window, we were able to start some early stage intraoral imaging studies. And it turns out that the optical sectioning is outstanding with Gary's probe and with the small lens, as you can tell and appreciate from these images of normal oral mucosa, different states of dysplasia, and an example case of oral squamous cell carcinoma. So it turns out that the imaging under normal conditions at least is better in the oral mucosa because we have much less scattering, we have much less aberration. The epithelial junction is more of a flattish junction, which is nice optically speaking, compared to the dermal epidermal junction in skin, which is in the form of hills and valleys. I'll show you some example images and video mosaics. This shows you the buccal mucosa, which, as all of you are aware, that's the inside of the cheek, the inner lip, side of the tongue, lateral tongue, back of the gums. This is the hard palate. And these videos will give you a sense for how the imaging works on the different sites. What you see in the videos on the left and in the middle are honeycomb patterns of cells. In the middle, you're seeing the epithelial junction. The video on the right shows you filiform and fungiform papillae on the top surface of the tongue. You will see bright, these are not now nuclei, these are bright nucleoli within dark nuclei. What you're now seeing is the epithelial junction opening up in the two videos on the left, the middle and the left. You will see blood flow as we begin to now image into the underlying lamina propria. And we're now in the lamina propria, and we can image a little bit deeper than what we typically do in skin. I hope these videos are playing for you, by the way, all of them. If not, I can play them for you again.
No, they're good.
They're playing.
Good? Okay, great. Our head and neck surgeon colleagues, Dr. Snehal Patel and his group of fellows, have finished testing the probe and the imaging on 80 patients. This was on patients before the start of surgery. And the objective was to look for the presence of oral squamous cell carcinoma, to look for tumor versus normal mucosa in the margins. And being a surgeon, Dr. Patel's objective was to see whether the imaging could help detect margins. And this is just to give you a sense of how the imaging took place in the operating room, in the operating theater. This was on patients before the start of surgery. And of course, these are patients who were asleep under anesthesia, so it was somewhat easy to do the imaging. And we gave him a microscope that was essentially driven by a laptop. So this was portable and could easily move from one location to another. And these videos will give you a sense for what we saw under normal conditions in a honeycomb pattern of cells, regular epithelial junction, regular vasculature. And of course, in the tumors, you see a complete loss of architecture. You see epithelial disarray, a disrupted epithelial junction, and a lot of vasculature. The features that we were able to detect, and we could, again, correlate some of these features to pathology, included multinucleated dysplastic cells, keratin pulse and focal keratinization, pleomorphism and epithelial disarray, lots of dilated blood vessels as expected. And under normal conditions, in the normal mucosa, we saw a nice honeycomb pattern of cells. And in this small study, Dr. Patel and his fellows reported that they could read these images for the presence of tumor with high sensitivity, and they could read these images for the absence of tumor with high specificity. Back in 2019, this was before the start of the pandemic, Gary cloned his probe, and we sent the second device to one of our colleagues, Dr. Marco Ardigo, who at the time was in Rome, but he is now in Milan at Humanitas University. Marco and his group of fellows have finished imaging on more than a couple of hundred patients, and these are now patients who are widely awake, who are wide awake in his clinical setting. They recently reported their findings in this paper and their initial experience. And what they did was imaging of 15 oral disorders and comparing features to biopsy and to pathology. So what they've done is describe the features for the different three types of mucosa: lining mucosa, masticatory mucosa, and specialized mucosa. As well as Marco has been working on building these tree diagrams, which can serve as a starting point for differential diagnostic algorithms. This is for the three different types of lesions that we expect to encounter in the oral cavity: white lesions, including leukoplakia, as well as oral squamous cell carcinoma; red lesions, which would include erythroplakia, as well as some of the other lesions; and pigmented lesions, which would include melanoma, melanosis, and some other types of lesions. Marco is also building these sets of features, a group of key features combined with a group of secondary features, which can help classify lesions and different states of dysplasia, particularly between low-grade benign and high-grade versus high-grade dysplasia and squamous cell carcinoma. And these are some of his example images. So under normal conditions, you see, of course, a nice honeycomb pattern of cells. You see a preserved epithelial junction. And what you're now seeing in the image on the right is early stage dysplasia. You see a loss of the pattern, a bit of focal keratinization. And in this case, what you're seeing is high-grade dysplasia with increased epithelial disarray, prominent dysplastic cells. And on the image on the right, you're seeing what you might see in cancers, in malignancies. And in a very small study, on a very small number of patients, Marco tested for sensitivity and specificity with these groups of features. And what he reports is that potentially we could get high sensitivity and specificity around 70, 80%. And all of this, would be on par with what we have achieved and accomplished for imaging of skin lesions and skin cancers. So all of this early work has now set the stage for what we wish to do next, which is larger studies for early detection, diagnosis, and management. And the goal now would be to look at benign oral conditions, look at inflammation, look at oral potentially malignant lesions and oral squamous cell carcinomas. And we'll see whether the imaging can help us triage benign conditions versus potentially malignant lesions, and whether the imaging can help improve specificity. Again, all of this would be similar to what we have done in skin. So back in September, at the end of September, we delivered 2 microscopes to Tata Memorial. And then in mid-October, Gary and I visited. Gary installed the microscopes. He trained Dr. Arjun Singh along with one of their head and neck surgical fellows, Dr. Amanjot Kaur Bains. And the imaging so far has gone really very well. This was the very first patient to be imaged. And I was told by Arjun that as of last week, they have finished imaging, I think, about 30 patients or so. So far, so good. The testing will be at 2 locations. One will be in a cohort of patients in Mumbai. This would be a high-risk cohort of patients. And then they wish to also perform testing in a cohort in the general population. This would be at the regional clinic in Varanasi. In the meantime, we are building now a combined RCM OCT microscope, and we're going to deliver 2 of these to a Tata Memorial later this year, with the idea that with OCT imaging, we may be able to look at the deeper architectural features and OCT images in orthogonal views. And we'll see whether OCT imaging can help us look at epithelial thickening, keratinization, epithelial junction invasion, and tortuous microvasculature, as well as OCT imaging can help us detect deeper margins, which can help guide surgery, which is what we have done with basal cell carcinoma in skin. That's a whole other project, which I won't get into, but happy to talk about it. We're also building the next generation microscope. So what we've done so far, as you've gathered, is simply taken one of our handheld microscopes for skin and rejiggered that with a probe at the front end. Not ideal, but enough to get us started. But what we wish to do is really build one specialized for intraoral imaging and to build it in the form of a smaller pen-like probe that would be easy to use on patients. So this work also is in progress. Okay, so with that, I'll wrap up by saying thanks to Memorial as well as thanks to the NIH, in particular the NCI, the NIBIB, and the NIDCR for being very supportive of all of this work. And since all of my work has been fully funded by the NIH now for many, 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 many years, I thank you all for your money, those of you who pay your taxes in this country. And thanks also to my wonderful team of engineers who build devices, engineers who build algorithms, as well as our wonderful pathologists, our dermatologists, our head and neck surgeons, our biologists who do all of the clinical work. And we do have our biologist with us, Aditi Sahu. So with that, I will stop at this point, Uma.
Thank you. That was a wonderful talk. Questions, please. Any questions for Dr. Milind?
I also have a set of slides which I won't show, but for any of you who's interested, I'm happy to talk about this offline or share these with you. So we've gone from the lab to the bedside, and then based on all of our experiences in imaging on patients, we've now come back into the lab. So we've gone back from the bedside to the bench to build the next generation of technologies. This involves combining RCM imaging with OCT imaging, combining wide field imaging with RCM imaging, machine learning algorithms, as well as video mosaicing. Again, happy to share more slides and talk about this with anyone who may be interested, but I'll stop for now.
Yeah, I do have a few questions, but I would let others take precedence if they have anybody else first.
Yeah, good evening. This is Sridhar. I work in Mumbai, and I congratulate Dr. Rajadhyaksha. It's the images, especially in the mucosa, are stunning. I mean, I'm a dermatologist, and the resolution is really fantastic.
Thank you. Yeah.
What my question is, what's the role of fiber optics? Could we go deeper? Could we do endoscopies?
Yeah, so I have colleagues at MGH in Boston, as well as, we have colleagues in industry who have built fiber-based confocal microscopes. In particular, there is this company, Monakia Technologies in France, there's OptiScan in Australia. And I think among all the devices out there, the one built by Monakia has been most advanced and is being used by GI surgeons to look at the GI tract, mainly on the surface, to look for early stage conditions when they want to do biopsy or when they do screening. At one point, that technology also had reimbursement codes, I believe. So that work has been going on. With fiber-based confocal microscopes, they don't work too well in reflectance or backscattered mode for all sorts of reasons, mainly fundamental reasons of physics and optics. I won't get into that. So what has been built has been mainly in fluorescence. And so the work has been mainly applying topical fluorescein or topical ICG for contrast. And with that, you can do imaging on the surface of the colon or the GI tract, but you can't image too deep. And these contrast agents are not particularly specific to nuclear morphology or to cellular morphology. So that's been the other challenge. So yes, there are fiber-based confocal endoscopes and microscopes out there. I don't think they've had as much clinical impact yet, but they're definitely being developed, or they've been developed, and they're definitely being now advanced in clinical studies.
Just one last comment. I mean, coming back to dermatology, the possibilities of AI and using the OCT and the confocal microscopy hybrid, what you are talking about.
Yeah.
I mean, these clearly are the way ahead, because the reason why, despite about 2-3 decades of work, this technology hasn't really become mainstream is because it lacks these software enhancements. These AI-based enhancements. This is, I think, the future for this particular platform. It's just a kind of an off-the-cuff comment, because there is huge potential here, and the reason one, and also ability to section it vertically. You see, pathologists and dermatopathologists, they're used to studying layers all at once, and that gives us a kind of a gallery view of what's going on in the skin. And so since this is essentially a horizontal sectioning, there are some limitations. So if we could come up with some kind of a sagittal plane imaging, digital enhancements, I don't know how feasible that would be, but yeah, these are some of the comments I could offer.
Yeah, no, agreed. I agree with you. And so it's interesting. So we can do imaging at an not truly vertical, but at an oblique angle, and that will give you, a representation of skin in vertical sections. We haven't really, I've not really pushed it forward into the clinic, but potentially we could do that. And I do think about whether, we really should do that. Interestingly, we found that over the years, the en-face approach have been appreciated by many of our colleagues, not so much pathologists, but dermatologists, because much of the imaging happens at the bedside in the hands of dermatologists. And although they were initially asking for vertical sections, which we could not provide because just the laws of optics and physics, they then realized through their study that the en-face orientation gives them a view of architecture at the dermal epidermal junction, and it gives you a pretty large view. And so that turned out to be useful from a clinical perspective. As well as what we do routinely at the bedside is collect stacks of images so that you do see images in depth, and they collect 3 or 4 mosaics so that you really look at a volume, look at morphology in the volume of the lesion, not just a single section. And so the disadvantage of en-face imaging have been offset by being able to look around in real time at the bedside. And so much of the work that has been done and much of the reading that is done at the bedside has been by dermatologists who don't have the bias towards pathology. That's how the field has progressed.
Yeah,
But I hear what you're saying. Yeah, I hear what you're saying. Yeah.
I appreciate what you're saying because we study the epidermis as it is viewed en face.
Yeah.
We study the diseases in dermatology en face. We register them en face. I agree with you. But thank you for your excellent presentation. In fact, I and Gopal work at the same center, and of course he's a younger colleague of mine and very much interested in this. So he'll be reaching out to you. In offline mode shortly.
Okay. Yeah, and again, I'll invite you to visit, my colleagues at Tata Memorial. I'll be there myself at the end of February.
Oh, certainly.
And take a look at the microscopes in action. And, I don't know if Arjun is with us. Yeah, he said he might join us, but I don't see him here. So, Arjun will be
I dropped
demonstrate.
Dr. Milind in the chat box. You can. I dropped my mail ID in the chat box. You can share your PPT as well as your contact details and travel plan so that I can get in touch with you once you land up in Mumbai, so we can have a one-to-one interaction. As I told you, Shiv sir is my mentor in this project, so he had done a lot.
Yeah, and Sridhar, I appreciate your thoughts about the need for machine learning and AI. We are doing some work in that. It's all early stage work. It will take a long time to get into the clinic, because it's a new technology. But nonetheless, the early stage research has started.
Yeah, in fact, I have another colleague, a junior colleague, who's also works along with Gopal in my department. He has made significant progress with machine learning with normal images, in dermatology diagnostics. It'll be very exciting to apply some of his software, and he has developed some software of his own in the field of dermatology. So maybe I could bring him along as well in February when we visit Tata Memorial.
Yeah, sure. Yeah, and we are happy to also build collaborations with anybody interested now with the intraoral imaging work. So we're talking to Dr. Praveen Birur at KLE Dental College in Bangalore, and also he works with colleagues at Madhumdar Shah Cancer Center. So in fact, my next grant application to the NIH is with Praveen and with colleagues at Madhumdar Shah. So we are happy to also build collaboration with any of you.
Wonderful. I think Dr. Amol had a query.
Yes, thank you, Uma. So coming back to your oral thing, what all sites can you image or look at? Is just the anterior 2/3 of the oral cavity, or do you reach the base of tongue and tonsillar pillars by any chance?
We can, so it's a straight probe. So again, it's not ideal for reaching all the sites, but we can reach, the front of the oral cavity is not a problem. The base I've seen in the hands of Arjun as well as Marco, it also seems to be not a problem if the patient is reasonably compliant. What you can't reach is the floor of the mouth and the roof, right? The hard palate, because those are just directly up and down, and we can't quite reach that with a probe. But otherwise, they're able to image and access most of the sites. But
so other than looking at just benign and malignant lesions for initial diagnosis, I think one of the challenges we face in oncology is post chemoradiation changes. Lots of times we have the system for response assessment, NIRADS, and one of the things is the superficial mucosal lesions. We can't assess well with imaging, and we defer to direct visualization, and it becomes a challenge. And I was curious how confocal microscopy would do in the setting of post-radiation inflammation and detecting residual or recurrent disease in that area of post-therapy change.
Right. I don't know the answer, but I think a study would help address that question. But what you say brings up this whole idea of imaging to guide treatment, which I did not talk about. And so we have a whole other project going on where we've combined RCM imaging with OCT imaging, and we have a combined RCM OCT microscope. And most surgeons have been using the microscope. So they use RCM imaging to detect and diagnose basal cell carcinomas, which can be imaged also very well with OCT imaging. Then they use OCT imaging, which goes deeper to look at the depth and the deep margins and to do a bit of subtyping. And with the OCT imaging, they can now triage basal cell carcinomas into those that are of the superficial, early nodular subtypes. And these are being treated now not with surgery, but with non-surgical approaches like laser ablation or topical therapy. Versus those lesions which are deeper than about 200, 300 microns, they tend to be the micronodular infiltrative aggressive subtypes, and those have to be treated with more surgery or with surgical excision. And then they've used imaging to confirm for clearance on the patient after laser ablation because there is no pathology to be done. And then most surgeons have been doing follow-up on these patients. And so far, they've done imaging for follow-up out to 6 years to monitor for any recurrences and to just, for surveillance. And all of this work has been submitted to a journal. It's all new data. But I think what you say, Amol, would be along the lines of imaging to really look at the effects of treatment, right? And it's all new. I mean, we haven't done any of this in the oral cavity yet, but I imagine all of these studies would start happening once we start building more devices. So again, happy to work with you or happy to collaborate.
Is there a reason you've been collaborating mostly with Mumbai? Any other collaborations going on in the US, for example, other than MSKCC?
Well, so I have many collaborations with colleagues, but mainly on the engineering side. For example, I have colleagues at Northeastern University in Boston, and that's a machine learning AI and a computer vision group. So we've been working with them for our machine learning work. I collaborate with colleagues at Montana State University. I collaborate with colleagues in the industry, but that's mainly for building technology. For clinical work, it's been mainly at Memorial with my colleagues in dermatology and our head and neck surgeons. And with Tata Memorial, we can blame Aditi for making that happen because Aditi worked at Tata Memorial and at ACTREC. And as luck would have it, she joined us after finishing her PhD. And through Aditi, we started working with Dr. Pankaj Chaturvedi and with the Tata Memorial Group. Just going
I have a few
head and neck Texas.
Yeah, I have a few head and neck colleagues who may be interested in the US. I'll connect with them and see and ask them to reach out to you for collaboration because this is exciting work, and oral cancer is pretty common and biopsies are painful. So
true. Yeah, we do have a colleague also at NYU, Denise Trocheset. She's the head of oral and maxillofacial pathology. So she too has shown interest. And the other reason why we haven't done much is because we've just built these devices. They're very new.
The trials in US are much more expensive than elsewhere. So that's
true. That's true. And they proceed at a slower pace.
Yeah. But anyway.
Hi, this
sounds good.
Hi, this is Chitra. Outstanding talk. Amazing.
Thank you.
I was just wondering, I know the collaboration in India. Like, how do you go through the approval process based on industry guidelines? How do you utilize your apparatus there? And how do you get funded in India? I'm just curious about India. I know you have it all down pat.
So this work at the moment is funded by my grant from the NCI. And the NCI has a program to support the building of what they call as affordable technologies for global health. And so I've basically got a couple of grants funded, and we are sharing money with colleagues at Tata Memorial to do the clinical work. In terms of going through all of the IRB-related processes, it was similar to what happens here and what happens at Memorial. We had to get clearance from the IRB or what's called as the Institutional Ethics Committee at Tata Memorial. We had to get clearance from the HMSC, the Health Ministry Screening Committee, which looks at all grants and collaborations involving overseas groups. We have to get clearance from India's FDA, the CDSCO, the Central Drug Standards Organization in Delhi. So these microscopes have been cleared to be used as investigational devices at Tata Memorial. So to answer your question, Chitra, many of the steps we've had to go through are pretty much similar to what we have to go through here. And so we have to work closely with our colleagues at our Memorial and other colleagues in Mumbai to make all of this happen. And it turns out that the rules are such that we cannot get a grant funded and share money from the NIH or the NCI until we get clearance from the HMSC in New Delhi, the Health Ministry Screening Committee. So we managed to figure out that process as well, we meaning mainly Arjun and Pankaj. Did I answer your question?
Yes, awesome. Thank you. Thank you.
Hi, Milind. This is Raj Kothapalli from Penn State.
Hi, Raj.
Thanks, Chitra, for asking that question, because we have an R33 Global Health Initiative grant, and we are going through that with IAC Bangalore with portable photoacoustic device for vascular diseases. So I'm going through all that protocols like ICMR clearance and the HMSC and all. So I know it's a very painful process to translate and all of that. So besides that, thank you very much for this excellent talk. It's very enlightening for me from many ways, like as we are also transitioning our technology to test in India. So my questions are a little technical. So you mentioned about this the portable like confocal microscopy device that you are testing. So I'm guessing you are using a laser there, right?
Yeah, it's a diode laser.
Oh, it's a diode laser. It's still portable.
It's portable. Yeah, portable. It's a handheld device. I can. Do you want me to go back to the PowerPoint and show you?
That's fine. That's fine. I was just curious with their use. So the similar a strategy we applied in our mobile healthcare for the acoustic device. We went from typically people use lasers. We now switched to laser diodes and light emitting diodes. That's what helped us. So I was curious whether you're using laser, and also their AI could help again to for example, if you get images from laser versus laser diode, and you can use a transfer learning approaches to see if that can. So that was other question was we are also building microscopes that can measure kind of optical elastography techniques. So with handheld, so we are trying to see what are the potential applications of those. In that sense, I'm wondering, from all your experience with working in oral lesions, how much of information or valuable diagnostic information elasticity can provide for mapping the early lesions?
Don't know yet. We are at the early stage of our work with oral imaging in the oral cavity, so don't know the answer to your question. But it's another line of research to be done, studies to be done.
Good. Yeah, thank you very much.
Yeah.
So I might reach out to you if I have further questions about the HMC or other approvals.
Sure, yeah, definitely, yeah. We have gone through this twice now with the 2 grants, and so we've become familiar. And to the credit of HMSC and the CDSU, they are beginning to improve their processes. So it was a bit messy, when we did it for the first grant, and there were long delays. But then when we did the process for the second grant, it was easier. And so things are getting better in terms of them the government agencies and offices streamlining the processes, because more of this is happening now, right? These international collaborations.
This
is Jyotsna here.
Go ahead, Jyotsna.
Yeah, so excellent talk. I really liked the way it was all put out. And I just wanted to know, like, in case we want to collaborate from our side, is it possible? We are a corporate hospital, so can the surgeons get in touch with you? How would we go about?
Yeah, I mean, in terms of collaboration, what you would need is a device, right, to be installed at your hospital. So we can surely, that should be easy to do, because we can work with my industry partner.
Okay.
And then we'll have to think about funding. I don't know whether, I suppose we could write an NIH grant, or you could look for funding within India. To answer, I think somebody had a question about funding in India. So Arjun is looking at what grants we can write in India in partnership with us. So while I'm busy writing, grants to the NIH, Arjun and I and Dr. Chaturvedi are going to start writing grants to funding agencies in India to
Yeah, I
support.
think there are ICMR grants that do these kinds of things.
Right. And Arjun mentioned something called BIRAC, BIRAC, which I'm not familiar with, but I haven't yet figured out what that is.
Department of Biotechnology. That's an arm of the Department of Biotechnology, and they fund research that can lead to commercialization, which already are having some kind of a proof of concept. So they have different categories. Exploratory is also there, but not to very primitive, only idea on, but some proof that can be taken forward are higher levels where you already have a demonstrated technology but want to commercialize. And they have layers of that. Yes.
We can definitely talk about all of this because to me, it's very exciting to be able to, work with many of you. And, as I mentioned at the end, what we've done so far in terms of technology is okay for a start, but really we need to build a much smaller device to do imaging in the oral cavity. So there is plenty of potential for development and building the next generation of technology. And I'm happy to partner with anybody, any of our colleagues in industry to make this happen. In fact, we're looking at something similar with Arjun and with colleagues in Mumbai as well.
Wonderful. I think Dr. Milind's email has been shared by Ruchi on the chat box, so people would like to contact him is there. But I also see a couple of questions for Dr. Milind in the chat box.
In the chat? Okay.
Dr. Kyle, yeah. It says, will it be useful for imaging the basal cell carcinoma in the conjunctival region of the eye?
Funny you asked that question because I got a similar question from one of our pathologists literally 2 weeks ago about whether we've done imaging of the conjunctiva. And there has been interest off and on over the years, especially to look at conjunctival melanomas, I think, or ocular melanomas. The answer is that we haven't done any imaging in the conjunctiva. But I mean, potentially it should be possible, right? Because it would be easily accessible to the microscope or to the lens of the microscope.
Yeah, food for thought. And there's another follow-up question. Is it possible to differentiate BCC from squamous papilloma using this methodology?
Maybe I'll punt that question to Aditi. Aditi is a BCC expert, by the way, because she spent many years imaging of basal cell carcinoma with RCM imaging and more recently with RCM OCT imaging. And again, if I do have a few slides to show our work with imaging BCCs. I'm happy to show that to all of you right now if you have interest. But Aditi, can you answer that question?
Sure. We haven't done any imaging of the papillomas, but we've imaged wart-like structures on skin, and they appear very different from what BCC does. So I'm going to say yes. I think we should be able to distinguish them.
Any further questions on that note? No?
Would you like to see the BCC work, Kyle? Or I can also share the slides with you separately.
Wonderful.
I mean, if it is possible to differentiate means then it could be easy for the diagnosis and all. That's what I have asked that question.
Okay.
Yeah, it should be helpful there because papilloma, I'm assuming, is like a wart-like growth. We've imaged those on the skin and BCC, and they are very different. We can tell when it is a growth of the keratinocytes versus when it's a growth of the basal cells, which is basal cell carcinoma.
Yeah.
So I'm guessing, yeah.
Thank you. I think that was a wonderful session. It's a very great way to start the new year with a lot of potential collaborations.
I love it.
And I think there's also a lot of interesting thought processes. It's a very different technique, and I'm sure that we just hope that you would also come back to show some of your ex vivo work that you were discussing earlier that you would like to show some other time. So I think I'd like to thank you, Dr. Milind, and I don't think this is the end of the talk, but I think it's a beginning of a lot more discussions and collaborations that are going to pass through emails. And I thank everyone for such a wonderful and active participation. Made the session really lively. Really, we didn't know it's actually 10 p.m. in India, but we didn't know that it took all that time. It's so wonderful. Thank you all.
Yeah, thank you very much, Uma. And once again, thank you, Jyotsna, for your invitation, and thank you all for attending. You know, I love all the questions and the discussion, and we'll talk more, and we'll figure out ways to collaborate. And again, do visit us at Memorial when you happen to be in New York City, and I'll let you know when I'm going to be at a Memorial in February.
Yeah. Thank you and Happy New Year all.
Thanks. Bye-bye.
Bye-bye.
Bye.
Bye, everyone.
Thank you.